there's no going back. That's what a lot of people say about the dramatic growth of telemedicine the past few months. And talking big leaps in utilization. Here's just one example in the US. At NYU Langone Health, daily telemedicine visits to urgent care increased 135% from March 2nd to April 14th, and over 4,000% for non-urgent health matters in that same time period. So we do know now what's possible with telemedicine in a crisis. Have we met the and it's what we see, just slightly ahead of schedule? Will it outlast the underlying drivers of the pandemic? Will it access to care and improve equity, or further reveal divides along these lines in our society? And what about the equally important contribution that telehealth is making to drive learning and improve clinical skills all over the world? These are the questions that have prompted our topic today, and that led us to invite people rich with experience in these spaces to our hour together, Dr. Reed Tuckson and Dr. Sanjeev Arora. And we welcome back IHI's Don Berwick and Derek Feely. They're our regular expert panelists on these virtual learning hours. So hello to all the panelists. Thanks for making the time to share your expertise and your perspectives. And hello to everyone joining us. As usual, you'll hear from our panel for the first 30 to 35 minutes, and then we'll turn to Q&A and discussion. You can chat in questions and exchange ideas at any point during our hour together. Just be sure to chat to all participants so everyone can see what you're thinking about. So we're going to start with some framing and perspective on Berwick. Don, I'm not one who talks in terms of the waving of a magic wand, but telemedicine sure seems to have been operationalized pretty darn fast the past 2 months. It's used and proving useful in this pandemic in all kinds of ways. How do you assess what we've witnessed so far?
Thanks, Madge. And let me first begin by thanking my good friends Reed and Sanjeev for joining us. What I thought would take many years has happened in weeks. The absolute soaring of telemedicine and telehealth outreach in the COVID crisis is nothing less than stunning. I was talking with a good friend who is the head of a multi-group physician group, where telemedicine visits went up from 100 a week to 10,000 a week. We'll hear from Reed and Sanjeev about the percentage overall, but it's really stunning. What's happened is the technology has surged into place. The need for it among practitioners who can't leave their homes is evident, and the infrastructures are also coming into place. It was just this week that CMS announced further decisions about payment for telemedicine visits. Perhaps our guests will talk more about that. So the financing is coming into place, and I think the skill base is growing fast. We're going to hear in this session a distinction that Sanjeev taught me between telemedicine and telehealth. I actually don't know if that's a conventional vocabulary. By telemedicine, as Sanjeev uses the term, it means reaching to patients through virtual encounters. Telehealth, Sanjeev uses to refer to coaching healthcare providers through telehealth, building their skills, which is absolutely essential in this COVID era when everyone's learning about clinical care processes and so on, and both are getting a lot of traction. This is really transformative. I think we've got a long way to go too. I think we're going to learn what the new configurations are like. IHI's Leadership Alliance has a project being led by Doug Eby called "Is the Office Visit a Dinosaur?" And it's an edgy inquiry as to whether COVID or non-COVID, we would want to have a different way to reach out to health people. So I'm very excited about what's going on. We've got a lot to learn, and I couldn't think of better teachers than Reed and Sanjeev today. So thanks a lot. I look forward to sitting in.
Thanks, Don. And it's true, telehealth and telemedicine have some distinct meanings in certain circles, and I've also seen them used somewhat interchangeably. Hopefully our experts can let us know how much that matters and what are maybe the important distinctions, as Don has suggested. So, Reed Tuckson, pleasure to meet you and invite you into this discussion. Your own background has definitely put you in the sort of this space of telemedicine with the American Telemedicine Association. How do you view what's happening right now because of COVID-19? And I'm wondering, are you surprised by the unbelievable, almost like flipping of a switch? How does that score your sense of what was going on?
Well, first of all, it is exciting and it is fun. Certainly, I have, like everyone, been surprised by how rapidly this is moving. But that being said, this was a movement that was well underway prior to COVID. I was president of the American Telemedicine Association about 4 or 5 years ago, and I remember in my keynote final address to the convention was the first slide was telehealth is now mainstream. So I think that we have started to see that the fundamentals of this have been in place for quite a while, but I think no one would have predicted just how rapidly some of the rate limiting steps have been removed. Again, this idea of remote delivery of healthcare services and clinical information using telecommunications technology, using internet, wireless, satellite, and telephonic media, its time has really come. I think what's important now is realize it's a multi-billion-dollar industry. And if you look at the capitalization now of the capital markets that are out there and the available capital for building and growing these businesses, it is huge. And so inevitably, there will be the dollars in the tank to allow this innovation to be scaled and to continue to advance. I think it's also important that we don't think about telehealth only in its own silo, but also realize it is part of a collaborative of things that are occurring as we move to consumer-centric care with digital tools rolling into healthcare, mirroring consumer-based industries. Telehealth is very much a part of that. So the idea of having weight scales and portable thermometers and portable blood pressure cuffs and remote heart monitors and glucose monitors, all of these are now of a whole moving us forward into a new era of healthcare. I think we know that value-based reimbursement, social determinants of health, advanced analytics with artificial intelligence, all of those are things that also move telehealth forward as part of a continuum of a changing paradigm of care delivery. Certainly, COVID advanced it more rapidly because of the CARES Act, and we can talk about some of those in a moment. In terms of it's allowing us to remove some of the barriers to adoption that came from that. But people are now, as you indicated in your introduction and in Don's comments, we're now seeing the ability and the practicality of triage capabilities so that you can do screening and assessment of a person remotely, refer those that are most appropriate for testing for others who need to come into a clinical visit, being able to assess, do they go straight to the ER or go to a more step-down environment that doesn't cause condensing and crowding and social distance challenges in the emergency room. We're seeing it able to identify symptomatic people who should be staying at home, but not so sick they need to be in a hospital, and then manage them remotely. That has become a huge opportunity that this has done. It also enables us to find people who have chronic illness, who we don't want to come to the hospital for the continuous management, but now can manage them in an ambulatory offsite environment, thereby not risking the patient's travel and not risking the hospital staff. And that has been terrific important. And then, of course, and then this has been a kind of an unrealized benefit that most of us would never have thought of, and that is enabling physicians who are quarantined because of exposure to the virus to continue to contribute, to continue to be online. And what I'm seeing among colleagues of my age, retired physicians who were not doing clinical practice every day, allowing a lot of us to be able to get involved in supporting our frontline clinicians by taking some of the back end out through telehealth kinds of opportunities. And so we're seeing an enormous amount of new things that are very relevant to this particular moment. I think what I would, there are certainly implementation challenges, and we'll get into those as you indicated later. So let me just conclude my opening remarks by sort of reminding about some of the good things that this CARE Act has done to move us forward. And that's particularly in the area of reimbursement. So the CARES Act applies to Medicare and what CMS does. Number one, they very importantly pushed to say that now reimbursement for the telehealth encounter is at the same financial rate as in-person visit. Number two, there used to be restrictions on how you could bill the feds for care if you were in an urban environment and other sorts of care environments. Now, rural only rule has now been waived, and other sites of care, including nursing home, including in-home care, as could be originating sites for this, eligible for reimbursement. Also, federally qualified health centers and rural health clinics are also now able to be involved. Number two, the kinds of service modality that is reimbursable. It used to be that it was phone only was not allowed. It had to be audio and video. Now, phone interrelationships are now billable during this crisis period. We also noticed that the previous relationship with the physician rule has been changed. It used to be that to be reimbursable, you had to have 3 years of experience with the patient. Now that has been waived, and that is a very important rate limiting step removed. The cost sharing prohibitions are now also removed. You are now able through telehealth to be able to prescribe DEA prescriptions with certain constraints, but you can now do that through telehealth without the in-person evaluation requirement being in place. And then, very importantly, for all of us at IHI, is the notion of how data will be moved from point A to point B in a crisis. There have been HIPAA relaxations and waivers that will now be applied. This has to be done very carefully. Of course, no one is going to play fast and loose with people's data, but some of the prohibitions around HIPAA portability have been relaxed. And then lastly, billing modifiers are now much more in place, and the AMA has done a very good job of creating guides and tools for how to bill and what modifiers to use. I'll conclude, though, on the reimbursement side, that's feds. The Medicaid is continuing to be state by state. And so you have to be very, very careful of how you look at what Medicaid will reimburse in your state and what the rules are. They're taking their guide by and large from the CMS guidance, but there are still peculiarities state by state. As far as commercial insurers are concerned, again, I think they have gotten on the bandwagon pretty well, but private insurance, of course, is complicated by whether or not that insurance is by the employer sponsored, by the health plan themselves. And so you have different rules and regulations depending on the nature of the sponsor of the health benefits. But overall, my conclusion is this is a genie that is out of the bottle. It ain't going back. And its time is here. There will be some issues going forward, and we can talk about those later, Matt.
All right, thank you very much. I'm just going to ask you one quick question, which I know is a complicated subject, and we will talk a little bit more about challenges in a few minutes. When you speak to the issue of the Medicaid reimbursement, maybe not quite in lockstep with what else you were describing, that of course does seem to suggest that these issues about equal access to this technology and possible divides in terms of utilization, just one of the many areas that I know people are concerned about, could further separate who gets what, through this period of time.
No, that is a very legitimate and reasonable concern. I mean, if you think about those states that were already reluctant to expand Medicaid coverage to their population more fully, you get this divide, this tragedy. You also have within the state not only the regulations and rules, but the availability of broadband technologies. I mean, this also threatens to significantly further the divide if states are not investing in broadband availability within their environments. And so on the one hand, this could be problematic. On the other hand, let's also realize that there are a lot of smartphones out in the land with people of very different across the socioeconomic divides. And so that we do need to take advantage of those technologies. If you go to Africa and other third world countries that are very poor, we notice that their use of their smartphone technologies to conduct telehealth interventions is very advanced. So on the one hand, it could be of concern. On the other hand, this may present us new tools that give us a chance to close that divide.
Good issues there, and I appreciate that. Talking about people all over the world using smartphones is a nice kind of lead-in to speaking with Sanjeev Arora, also joining us. Many of you may be familiar with Echo. We really wanted to combine what Sanjeev is doing in this space because the telemedicine, the direct clinical encounter with patients is getting a lot of attention, but there's a whole other revolution taking place in the space of Project Echo. So Sanjeev, feel free to build on anything either Don or Reed has said, and tell us your observations right now.
I think that so when I look at telehealth, there are two broad applications. One is this application that Reed so eloquently described of helping patients directly. What we like to do is something slightly different, which is telementoring, in that we are trying to solve a slightly different problem, and that is the problem of there's an exponential growth of knowledge occurring in the world. And there's a shortage of experts to deliver that knowledge at the last mile of healthcare. And we know that patients have a difficult time reaching or accessing the right knowledge at the right place at the right time. And if they can't do that, bad outcomes occur. So for example, 1,800 children die every single day of diarrheal diseases. When we know what the treatments are in the world. 1,100 people die in India of TB when the medicines are free and the diagnostic tests are free. So I think there's a problem of getting the right knowledge at the right place. And so what Echo is based on is really a slightly different idea, and that is, can we use technology to exponentially expand or amplify the capacity to deliver best practice care, which is a slightly different twist on using technology. So how do you exponentially expand this capacity? There are sort of 4 components we think are required. One component is dissemination of knowledge. You have the knowledge, you got to get it out there to everyone. The second component is how do you mentor rural providers everywhere in the world, urban providers, to implement that best practice? And in Echo, we use the same model we learned in residencies, iterative guided practice, learning from each other. Don Berwick, I've been a fan of his ever since I first heard him at an IHI meeting. And he's described this concept of all teach, all learn. This is really important for us because the reason in Echo we use all teach, all learn is because this best practice doesn't originate just from the hub or the experts, but it has to originate from the periphery because that they have the local social, cultural, economic circumstances in which they operate, the resources, human and other resources available there. So that's the second part of this. The third is that a lot of our healthcare providers in the world, including nurses and nurse practitioners, etc., have not been trained on process improvement, quality improvement, patient safety, error reduction. And we know from 3 large studies that this is a huge problem. And that mentoring and training has to be done. And the last is, we haven't received enough training in how to work in teams. So Echo works on all of the, Echo is an implementation scaling platform based on telementoring, which is a complement to the amazing ability of telemedicine providing care, whether it's in an ICU or at home to a patient. But when these are combined together, it can be extraordinary, the result. And the slide you've shown us right now, so we started Echo at the Echo Institute for one disease, hepatitis C. And we were able to show through research that when we got 25 or 30 clinicians together to learn from each other, present cases to each other in de-identified ways with experts, they all became experts. And we published in the New England Journal of Medicine that they could give interferon and ribavirin treatment as well as rural doctors. Subsequently, we also showed that it was producing joy of work for them. It was reducing their isolation, increasing their professional satisfaction. And then when we realized that 6 billion people in the world don't have the right knowledge at the right place at the right time, we figured out we're going to train other academic hubs in the world to do it. And now most of the major universities in the world have deployed ECHO. We have 393 hubs. They run 850 separate programs. Before COVID-19, we had 106,000 mentees in 154 countries, working in 22,000 organizations in the world. And you can see at the bottom right, there's been exponential growth in knowledge. But since COVID-19, we basically redeployed the ECHO network for the primary purpose of amplifying two things: the public health response, one, and the care delivery response, which are two separate things. The public health response has to do with testing, has to do with isolation and policy and setting up testing sites and how to get PPE, etc. Whereas the care delivery is, like Reed said, should the patient be seen at home? And in fact, in the care delivery, we are doing echoes of how to do telemedicine, because that also requires best practice knowledge and mentoring people to do telemedicine with quality and effectiveness. So I really see telemedicine and telementoring going hand in hand to create a more highly functioning health system for us. I'll stop here.
Well, that's a nice image and a nice aspiration. I appreciate it. I'm going to ask Derek Sanjeev. Lots of comments in the chat. We can see that you and Reed are definitely stimulating all that. Derek, I want to bring you in for anything you're hearing and reflections, and then I'll come back to Sanjeev and Reed for another question or two before we go to chat. Thanks, Derek.
Thanks, Madge, and thanks to both Reed and Sanjeev for raising such important issues. I agree with Reed that the genie is out the bottle. I think there's no going back, and neither should we attempt to do so. And at the same time, we need to be thinking now about how do we need to recalibrate our quality management systems to recognize this new way of delivering care, because our approach to quality and indeed to improving that quality is focused on the old way of delivering care. And so, how do we, to borrow a phrase I've heard Sanjeev use before, how do we democratize the knowledge of quality improvement to make sure that it gets into the hands of people? And I think telemedicine and telehealth can lead to improvements in outcomes for our patients. We know that to be the case, but there's no magic. It's not automatically so. We need to design quality into our telehealth and telemedicine solutions. And we need, I think, to look across the whole spectrum of quality. Most of the benefits that people have been seeking from telehealth and telemedicine are around access. And that's important. But what about equity? So how do we make sure that there are no technical or connectivity barriers? How do we make sure that there are no cultural or trust barriers? How do we make sure that there are no financial impediments? And so that we can get equitable outcomes from our telehealth and telemedicine solutions. Sanjeev, I think, has already demonstrated that it's possible to get more effective outcomes from telehealth solutions than from the alternatives. But how do we make sure that's the case for every patient every time? And that I think, for me, Madge, is the exciting prospect, is can we get alongside the pioneers like Reed and Sanjeev with an approach to managing quality that meets their aspirations. And then the final thing I would say, Madge, is we ought not to make any assumptions about this. As I was listening to Sanjeev and to Reid, I was reminded of a time back in my old world when I sat in on a telemedicine consultation between a physician and a patient. The patient was in one of Scotland's remote island communities. And I listened into the consultation, and I said to the patient at the end of it, it must be great that you don't have to travel all the way into Glasgow from the islands to get this consultation. And he went, yeah, that's good. He said, but that's not really the main benefit for me. The main benefit for me, and he swiveled round his camera, is my daughter's in the room. And she's my full-time carer. And it means that she can listen to this whole conversation. And I get continuity of care, is what he was saying to me. And so we ought not to make any assumption, but I think we ought to look at the value of telemedicine and telehealth sometimes from the patient's perspective, and not make any kind of assumptions about what's the quality dividend that they get. But I think what Reid and Sanjeev have given us is a real view into what's possible here. And I hope that the people who are listening into this call who are largely a quality improvement community will now come alongside this and help us figure out how do we get better quality of care through telemedicine and telehealth. How do we make sure it's safe and reliable for every patient every time?
Thanks, Derek. And as we'll say a little bit more towards the end of the hour, this is the space that I think the safe quality and metrics and what we want to be pointing out, that one of the areas IHI is hoping to develop some programming and work in. So we hope to be able to continue to tell you more about that. All right, definitely the chat is bubbling here. I'm going to go back to Reid and Sanjeev quickly, and Reid, in terms you can see, you probably had some thoughts on your own, and you can see what is going on in the chat. I guess my major question to you might, to what extent does the provider community and maybe even any of the industry associations see itself as starting to, in any way, advocate for, the other side of and the patients and the needs to make this really more sustainable?
Well, I think the industry and certainly and the AMA and others are definitely addressing this now, and particularly because of the issues that Derek raised and Don raised, which is the quality concern. I think that that's really what we all have to focus on. We've got to make sure and remember that for patients, their main issue is always going to be the quality of access to care, quality of care, but also the cost of care. And so we're going to have to make sure that when these things are implemented, that it's not going to drive up unit costs. It's not going to cause redundancy in care delivery that the patient has to pay for. By the way, American people already cannot afford to pay for what is out there now. So we have to make sure this is going to improve access, improve quality, but not add to the cost burden. I'm particularly also focused on the quality side around, this is going to be a very complicated workflow and culture that telehealth has to have, because we're integrating a lot of things. Telehealth implementations are not just looking at, a device connected to a person. It's scheduling, it's the therapeutic intervention, it's care management. All of these are a part of the telehealth continuum. And so that means that how those pieces fit together, data sharing, interoperability of that data, how a patient interacts with a physician, interacts with a specialist, how that comes together, the evidence basis around how to make that a seamless process where you don't drop things in between all those handoffs, but it's seamlessly coordinated. So how do you have the best evidence of best practice, how to implement that in a way that gives you the best quality, that the patient gets a complete holistic centered approach and not a piecemeal approach, so where we divide up the patient again, which is what we were trying to get away from, So this has got to work to create that whole picture and whole engagement of the patient. And that's going to require new evidence, especially in the health services field, that teaches us the best way to do this in a quality way, but also in a way that doesn't drive up costs.
Thanks, Reed. Sanjeev, let me get your any quick thoughts, and then we'll hear from Don Berwick, and then we'll go to chat. Let's make sure to get your mic off. Hold, mute, unmute.
Yeah, I think the real issue for me, of course, is that we need to work to improve quality, not just volume. So I think that is very key. To improve quality, the way I've thought about it is you need to know what to do. That's really important. But then you need to know how to do it. And that how to do it piece is what we in ECHO particularly work on. And that's where how to do it, I've heard about PDSA cycles a long time, but really the issue for me is, I know I need someone to hold my hand to implement quality a few times for a few problems. And once I do that and get the hang of it, then I can do it for a whole lot of things because it's a way of thinking. So when we faced with the COVID-19 and we did this shift, we already had 220 peer-reviewed publications pre-COVID-19 showing that, look, we can improve quality in different areas and so on and so forth. But now we were faced with a much more difficult challenge, and that was how do we rapidly scale up? So the first thing we did is we set up 9 separate ECHO projects in New Mexico. We have 2.3 million people who live here, 9 a week on different aspects: infectious disease office hours, first responder resiliency, with psychiatrists, ECHO for education, having actually K through 12 teachers learn how to do virtual classrooms, our doctors learning how to do telemedicine, and then community health workers on how to do contact tracing, isolation, quarantines, and all kinds of different things, ICU care. But because the need was so massive in the world, we partnered with the federal government, the World Health Organization, and so far we have now trained more than 250,000 clinicians and first responders and community health workers in 100 countries on the COVID response. And again, dividing them up into either the amplifying the public health response or amplifying the care response. And the questions that we get, so for example, we just 3 times a week with the HHS and ASPR, we do this US-based call, and we get questions like, how should you ventilate a patient? What should you do? Can you get reinfected? Doctors have problems with donning and doffing and how to reuse equipment when you have a shortage of PPE. And really getting down from best practice to what are the problems they're facing, what exactly in their circumstance, and the solution is different in Africa from what is different in US. There is no best practice for PPE if you have no N95s applicable. So what ECHO is working on is, in your current resources, we don't want the perfect to be the enemy of the good. What is the best you can do today? And then as resources become available, what more can be done? And our latest focus, of course, right now is we know that in order to strangulate this virus and make it go away, there are really 3 ways to do it, right? We can, as I said, strangulate it by not allowing it to spread. We can have a vaccine, or we can have an effective treatment that will essentially be available for all 7 billion people. Now, the latter 2, the effective treatment for 7 billion people and the vaccine, RNA viruses have to be stored at -80 degrees centigrade. And even after a vaccine is developed, it's going to take a long time for the low-income people in the world to get it. So what we're left with is strangulating this virus, and that requires an army, millions and millions and millions of people around the world who know how to set up testing protocols, who know how to isolate patients without getting infected. They know to contact trace the 30 people that this person met before he got diagnosed. And then they know how to have the conversation with these 30 people, how to quarantine them, and then to follow them every single day on, do they have infection, testing them repeatedly, and when they get infection, contacting their 30 contacts. So all of this is what we are focusing on right now in the programs that you have listed and we have on this slide. I took your cue and talked about COVID-19 because you showed this slide, Madge, but I hope I wasn't off script here.
Not at all. I think people were interested. I could see in the chat of some examples of what types of issues were arising in those calls. So thank you for that. Don, real quick, and some thoughts from you, Don Berwick, and then thank you for all the comments and questions in the chat.
Yeah, I know I've met him. Some of the
thanks, Madge. Reed, let me just ask Reed a question. A lot of the comments in the chat are about cost. Can you say a few more words, Reed, about how you see the possibility of telemedicine reducing these unbearable costs in healthcare right now? And to be a bit edgy here, why the heck should we pay the same for a telemedicine visit as we do for a face-to-face visit, given that the overhead costs are presumably much lower?
That's great.
How can we use this to reduce cost?
We first of all, that's a great point. And this idea, though, of reimbursement is the rate limiting step, Don, for getting it out and getting it over the barrier, the hurdle. And so I think at some point, as telehealth becomes just health, and as it gets it stops becoming, which I think it about is now, Don, that it's no longer this exceptional thing off to the side. Years ago, I used to chair the Secretary of Health's Advisory Committee on Genetics, Health, and Society. Now, the idea that you would need an NIH panel on genetics, health, and society is ridiculous, because genetics is just medicine. I think telehealth is about at that place pretty soon. So once we get past all of this and we start fitting it into the normal reimbursement structure for how we reimburse hospitals through value-based reimbursement and how we do that for the ambulatory side, you'll start to see some of these things normalize out. But at the end of the day, if we're going to be able to, what this conversation around what is the cost benefit of telehealth inevitably will also be caught in the middle of the conversation about how America will go forward on redundancy of its hospital-based infrastructure and the redundancy of its supply chain elements. So we're going to have one level, there's going to be this conversation that says we may need to build in more capacity than we're used to. At the same time, what telehealth is going to be saying to the community is that we don't need that much brick and mortar, that so much more can be done through a different mechanism. But then you also have, Don, issues that will start coming up around, again, to trying to predict the answer to your question, will be that how do you build in the relationship between the telehealth capacity and the mobile remote monitoring capability that is connected to by the care managers that are connected to the in-home care support team. That in-home care support team, the burn patient who has frequent visits from a specialist who's in-home helping to manage the burn, with a telehealth relationship to the burn center and experts back at the mothership. All of these interrelationships, Don, give us the opportunity to coordinate things and make things easier and do them in the lower cost environment, not in the hospital. At the same time, there will be people trying to figure out how they configure those services, and then in a value-based reimbursement world, be able to extract enough revenue from doing these at each of those supply line chains, from the care manager, the in-home support, the burn specialist physician, and so forth. Each of them will traditionally want their cut in the money. So how does that all come together? That's the big challenge, on. But inevitably, the short version to responding to you is the very question you raised. And that is the very thesis you raised. In a non-hospital environment with its attendant costs, this should definitely take costs out of the system.
Thanks, Reed, and thanks, Don. Derek, you wanted to jump in?
I did. So firstly, I wanted to agree with the point that Reed just made about how payment systems are undoubtedly a rate limiting step. And I wanted to get both Reed and Sanjeev's view on something else that I've seen that is, I think, a rate limiting step, even in systems where payment barriers do not exist. In fully capitated systems, telehealth and telemedicine has been slow to get off the blocks. And the main inhibitor I've seen is what you might call professional protectionism, what I've heard Don refer to as the kind of guild approach, where people are afraid to let loose their professional advantage and to allow for that democratization that Sanjeev has talked about. Is that something, Reed, you see, or Sanjeev, that you would care to comment on?
Sanjeev, why don't you go first and I'll augment.
Getting back to Don's question about differential payment between telemedicine and this thing, Don, listening to you over the years, I've learned that you like to ask the right question. So I'm going to modify your question and ask a slightly different question. Is visit the right way to pay for healthcare, rather than asking the question whether the difference of reimbursement should be there? So because that really drives everything. As long as we are linked to the visit, whether it be telemedicine or not, it could truly influence us in the wrong way. Telemedicine will not solve the incentive problem here at all. It could make it worse. So I just want to make sure that is. I think that in terms of this issue of demonopolizing or democratizing knowledge, Derek, you are absolutely correct. Not every doctor in the world wants to democratize their knowledge, because knowledge is power, knowledge is money, knowledge is fame, knowledge is many things. And monopolies of knowledge create value. That's how the capitalistic system is structured. So I'm not naive enough to think that that will change overnight. But we have also found a counterbalancing force here. There are millions of doctors, hundreds of thousands in the United States, who want to democratize their knowledge. They do not have this motive. They have a service motive. They have a desire to serve. And we have never, in the history of ECHO, and as I mentioned, hundreds and hundreds of thousands of people now have been mentored on ECHO, had a shortage of experts who are willing to democratize their knowledge and mentor other people. You're right. It's not going to be everyone. But if I have 1 in 30 who want to do it, our model is that of force multiplication. We will exponentially expand that mentoring capacity to serve the world's to solve the world's problem. We don't need the whole humanity to change their mindset. I think technology allows us that flexibility. And so I'm very optimistic that it can be done.
And I would say, Derek, that an observation is that if you want to do anything around clinical care delivery, the physicians lead the culture. And so inevitably, every place that I have seen that has been successful in implementing good telehealth solutions, you first have got physician champions inside of the culture that are helping to lead the way. That always becomes key. Having said that, I think that what we now realize, again, with the changing paradigm and how care is delivered, we are moving towards teams. And I think physicians really, especially the physicians of the modern era, maybe not folks of my generation, but the ones below mine, which is just about everybody, is beginning to get the sense that this is a team sport. And this idea of the physician general, as opposed to the physician generalist, is a very different concept. Third, though, so I think the idea of knowing that we need a healthcare team where everyone practices at the height of their license is become clear. And I would think it would be very difficult for clinicians today, after the COVID-19 experience, where they're watching their fellow health professionals put their lives on the line every single day, for a physician to decide that somehow or another, we are more important than everybody else. I mean, I think this life and deathness has democratized a whole lot of it. But the last thing I would say where the guild effect is, and and you really, I think that's an interesting concept, is with our state medical boards. The problem that we have been having is the interoperability of licensure across state and regional barriers. And there you find that in the past, the state medical boards saw themselves as protectionistic of their individual docs in their state, so that they would be trying to immunize them from competition from others across outside of their borders. This has been an absurd fight. And what you find when you go into that is, the argument that is used is, let's just say, for example, the medical board of the state of Iowa doesn't trust for diddly squat the quality of the state medical board in Wyoming. So therefore, I can't trust that they have certified Dr. Smith in a legitimate way, and I'm not going to inflict him, a Wyoming person, on the good people of the great state of Iowa. So we will block that. And so we're now getting past that with this wonderful compact that the State Medical Boards Association is moving forward. Now that COVID has occurred and the CARES Act, we're going to see those things stood down. And I don't think it's going to be very difficult before long that we actually get to a national unified standard.
Don Berwick, thank you, Reed, and everyone. Inevitably here, what's happening is that I do believe that Sanjeev and Reed and Derek and Don are addressing many of the comments in the chat here. People are wondering about payment issues, quality issues, the access issues, training, which is going to be quite important throughout all of this. Don, as part of the question about performance indicators that would be helpful in this space right now, would you be willing to speak to that? And sorry if we're hearing another voice coming in. I'm not quite sure that's coming, but anyway, we'll talk over it. Somehow, there has been all this work in quality improvement. In some ways, we don't have to start from scratch because of technology here. There could be this temptation to think, oh, it's a whole new ball game. But indeed, we do know a lot about, or you know a lot, I'll say, about performance metrics and how they can kind of catch the same wave that's going on. What are some of your thoughts about how that happens? Because in some ways, there's still a lot of sort of siloing going on here in industry. People can order services and this kind of thing, but what brings it together?
As well.
I'm thinking sort of at two levels about that, Madge, and there are many, many questions about this, about protecting and improving quality. The first is some of the care being projected through telemedicine is the care we're familiar with. And I think we have to make sure that the standards of adherence to science that we would apply in any face-to-face or inpatient setting apply here as well. How you do that technically, I don't know, because presumably this is harder to monitor in some ways, but I would say we need to take what we know about adherence to science, the issues of safety and patient-centeredness and evidence-based care, and really get them into the telemedicine picture. I'm sure that Sanjeev and Reed have a lot to say about that. But the second is what, if you listen to Sanjeev and Reed, they're not describing only the projection of the prior healthcare system into the virtual space. This is a new kind of care. Several of the commenters are talking about the importance of co-production in the telemedicine world, which is a very exciting idea. Others have raised questions about non-physician providers. Sanjeev is taking his force multiplier idea and equipping people to do things they never could have done before. I don't think we should go back to the framings of quality that we brought from the past. We need to think about what the new quality is that we're after in this virtual environment. I think it would be far more empowering of patients. I think the possibility for immediate feedback from patients has gone up, not down. And I think the ability to think about forms of assistance that reach into the home in a way we've never done before is also there. So I think there'll be new quality parameters here that we need to look at. Let's not just repeat the past. Look, I know that Reed and Sanjeev have thought a lot more about this than I do, though. So let me
just make one commercial, Don, and you open up an important opportunity. I wrote a review article a couple of years ago for the New England Journal on the need for more research around how do we implement these systems. And I will say that I hope and pray that we can get and support the Agency for Healthcare Research and Quality, who I think is very interested. We've got to get more money into the research side of this immediately. And we also have to get more of our health service research community looking to do this kind of work. Don, IHI is all about evidence, and it's all about generating best practices. And I think here, given how fast this is now moving, there needs to be a much more urgent call. Now, what I fear is all the dollars that the federal government has is everything legitimately is going into trying to solve the COVID-19 crisis. And, you know, we're spending a lot of money with all kinds of bills and so forth. I can almost sort of guarantee you that without an active, aggressive effort immediately after we start to subside on this current frenetic pace around COVID-19, without Don, IHI and others being very aggressive in getting dollars through AHRQ, and they're not the rate limiting step here. We got to support AHRQ so that they can get the kind of studies that need to be done quickly and up to speed. But I have a feeling that this is going to get lost in the shuffle, and what we're going to find ourselves with is a vastly expanded capacity to do telehealth without the concomitant knowledge about how do you do it quality, how do you do it improving safety, and how do you do it cost effectively.
I think we could maybe take that as a challenge to all who are on the program today, in whatever position you are, representing patient groups, representing physician groups, wherever you are with respect to working with older people in our society, and where are they going to find a to this, so we don't suddenly lock others. I think those are all quite important. And one of the things I like about your point, Reed, is that I think people know inevitably here are somebody's asking, how can we, where is there a really good online for doing telemedicine? And I think there will be a rush to create even more products to support that. Folks are asking about getting this into medical school curricula, for example. And so the rush is on to see what is the body of knowledge we want to go along with this. So I appreciate all of that. I'm just going to ask, and because I promised somebody I would at least just throw out there the issues around other aspects of healthcare right now, including dentistry. Somebody said, could you please, all dental appointments have, been canceled, and we're always leaving out oral care. And I don't know if anybody wants to say anything on that matter, but I guess I just wanted to put in that plug on behalf of that person who emailed me. Sanjeev, I'm just wondering, is oral care anywhere on the radar screen as you have been conducting these Project Echo calls?
Yes, we have many echo calls related to oral care. Of course, the mechanical aspects of delivering a tooth extraction won't be done with echo, but yes, we have tremendous number of echo projects trying to enhance oral care by training people. I also want to take a crack at the question that Don and Reed asked earlier, is that I'm very optimistic that the lessons we've learned from the COVID-19 will result in long-term sustainable changes in our system. One, I see them, at least, of course, there'll be many changes, but the three things that I see, two which have almost certainly happen, is one is we will have a greater emphasis on public health and systems rather than just care delivery pathways. And I think that will be a really good thing, because the organization you led, Don, for Medicare, after there was an explosion in the care delivery system after the 60s, after the Medicare came into existence, but the public health systems got somewhat denuded as it didn't have a parallel growth, and that will happen. I think the technology used will definitely explode regardless of payment systems, I believe. But the one area that I am a little nervous is the area where I work in, that we would prefer if we don't have the training and mentoring and coaching of the healthcare workforce, from community health workers to doctors, linked to a visit, which it is currently. The Medicare payment rolls it into a visit, the provider training piece. And I think decoupling that and putting it into the public health arm for quality improvement and training and coaching is an essential thing. And I'm less optimistic about that. But I think this is really critical for us to have an enabled workforce if we're going to deliver a quality healthcare program. And so that's what my hope is. But the former two, I think, will almost certainly occur.
Do you have 1 minute left? Or did you,
Reed, you'll get the last word. Go for it. Thank you, Sanjeev.
I think just the dental one is fascinating. And I think, again, we come back to this new paradigm of care delivery where we're integrated as teams, and oral health increasingly being realized as a part of overall health. So you can imagine, again, the ability for, especially in an inner city or rural environment, to have doc-to-doc relationships to assess the oral health photos and the diagnostics and get a consult. Triage, how important is this? How serious is it? Being able to have an integrated system where the telehealth system can schedule the dental appointment for the patient, all as a holistic opportunity. So there are important screening and diagnostic opportunities that we have to stretch out the availability of scarce supply of dental providers and secondary consultants.
Okay, well, I can't believe we really spread through this, maybe not as fast as the internet, but pretty fast. Sanjeev and Reed, thank you so much for taking time out of your very, very busy lives and schedules to lend your expertise. Always thank you to Don Berwick and Derek Feely. I wanted to remind everybody, because I think we also have this slide, that we have an IHI COVID-19 global community that you're invited to join. The information is either on your screen or in the deck you'll find on IHI.org. That's one way we continue these conversations. And again, watch this space, as we say, as IHI continues to work on telemedicine, picking up on many, many of the issues that came up today. And you see some survey questions on the right-hand side of your screen that helps us understand what we can continue to do better with the show itself, and also some of the things that are burning for you about telemedicine. Virtual hours are one of the free benefits of IHI's new membership program during the pandemic, and we're sharing this with the entire IHI community. Again, thank you to our panelists. Thank you, audience, for taking the time to share your wisdom and interests. Please be on the lookout for the archived edition of this show, which will be posted to IHI.org later today and no later than Monday. We're going to be back next Friday with an important discussion about equity during the pandemic. So please stay tuned for that information. Details soon on IHI.org, and you can also find a lot of resources there. This has been a real honor and privilege for me to be moderating these calls the past several weeks, interacting with all of you. I can't express my gratitude enough. We wish everyone health and all the best. And for the Institute for Healthcare Improvement, I'm Madge Kaplan. Good day.